in medicine and every specialty, a little bit about the interview process, particularly in anaesthetics, but I'll touch on ICU as well, and then answer any questions that I can that we have time for in that 15 minutes. So some of the questions that my clients find really difficult are what makes a good anaesthetist? What makes a bad anaesthetist? How do you cope with negative feedback? And what would you bring to the role of ICU? So I want you just to have a little think about those questions, and I'll give anyone an opportunity to answer them in a little bit, or I'll give you some ideas on how I coach my clients to answer them. So what I have been doing for the last 13 years, I think it is training clients at every level for their very competitive interviews. I train clients for advanced training for emergency medicine, head of ICU, anaesthetics consultants, anaesthetic training, but intern, residents, registrar for every specialty, including set, advanced training, and basic training. I've worked with clients from every major hospital in Australia, including Royal North Shore, Royal Darwin, Prince Fiona Stanley, Queen Elizabeth, Charlie's in Perth, as well as every major hospital here in Melbourne. And I also go in and train at a lot of hospitals, groups, in particular at the Eastern, the Western, St Vincent's and Royal Melbourne. Almost all my business is from referrals from other clients that got into their specialties or their consultant roles. And before I started my business, I worked for an executive search firm, which is essentially a recruitment firm, and was involved in recruiting executives in health at large metropolitan hospitals and research institutes. So I would have probably interviewed over 1,000 executives there before I started my own business. And I kept on getting people referred to me who would come to me and say, I'm on my last year, or it's my last chance for my specialty interviewing. I don't know what I'm doing wrong. And these people were all such good doctors. So I really want to assure everyone that interviewing is a skill you can learn. And I haven't met anyone yet who is a natural born interviewer. In fact, often people who think they're born interviewers don't give the best interview, and it's the very modest doctors that are so good at what they do but feel really uncomfortable about speaking about themselves and all their wonderful achievements that I really enjoy helping. Obviously, for different interviews, you can expect different things. So for your intern interview, you used to get a group interview. I understand at the moment it's a recording of 5 questions. That's going to be different again from your resident interview. And of course, your specialty interviews are vastly different again. In terms of anaesthetics, which I think if you're considering anaesthetics, it's very competitive. And each program, Northwestern, Eastern and Monash, shortlist and interviews in August. And all of my clients are preparing already. Generally, you get the same initial question, followed by a variety of questions based on the hospital to explore the depth and breadth of your experience. And ANZCA set the selection guidelines. And they're looking for applicants that foster safety and explore the competencies of a medical expert, a communicator, a manager, a scholar, and a professional. So what makes a bad anaesthetist? I don't know if anyone wants to volunteer to answer that question, and if not, I'll just give some thoughts on how I would answer that question. Does anyone want to volunteer for that answer? So what makes a bad anaesthetist are qualities such as unwillingness to work as part of a team, poor communicator, someone who won't accept feedback, and who's not dedicated to their own and their team's professional development. What makes a good anaesthetist is simply the opposite of that. Someone who facilitates efficient care, can work with multidisciplinary teams, and ultimately can foster a safe environment. These are questions that, when you think about it, they're not that hard, but they do seem to throw people in their interviews. Negative feedback, how would you cope? You've always got to be prepared to give some negative feedback, and please, no deaths. Don't, when you're giving your negative feedback or your mistakes, just make it something small and not something really serious. You'd be amazed how many of my clients offer an example that's really quite serious and often is not their fault and doesn't reflect that well on them. So negative feedback needs to be looking at how you've reflected on something, taken it on, and what you're going to do better to make sure it doesn't happen again. Last year, a lot of interviews had a COVID question in them, which explored mental health and the way that you're just talking before about your clinics being overbooked, the stress on not elective patients not having their surgery, and what we're seeing now because of that delayed care. The ICU interviews are looking for people who obviously aren't faint-hearted, that it takes a very special type of person that can work with patients who are critically ill and help them recover as a direct result of that team. They want someone people who can work under pressure, work as a team, and make competent decisions and work efficiently. Knowledge and skills is obviously at the top of the list. So you should be expecting questions like, tell us about an interesting case you've had, your career plans, and disagreeing with a treatment plan, such as a proposed CT scan. In terms of my top tips in general for interviews, I can't tell you how many clients come to me and say, I didn't prepare last year. I didn't expect to get an interview, so therefore I didn't prepare. Always expect to get an interview and always prepare. Many specialties have a cap on the number of years that they're allowing you to interview, so it just doesn't make sense not to prepare, and it's too competitive. We know that in some specialties you might have one place and 20 participants, or 200 applicants for 7 places. Eye contact's essential, reading the panel, researching the hospital that you're attempting to join. Basics, turn your mobile off. Understand how to interview on Zoom, if that's how you're going to be interviewing. And also understand that everyone can be a good interviewer. It really just takes practice and an ability to think about your own answers. Anything you read on the internet, everyone else is also giving. So my other tips to you would be, when you're preparing, think about how you're going to answer that question and give your own experiences. Sometimes I've heard the same answer 4 times, and that's not going to impress a panel. You can see a lot of details about me and what I do on my website. There's lots of testimonials from any of the specialties that you may be interested in. Last year, I had 80% of my clients achieve consultant and head of unit roles, 100% of many advanced training specialties, including 75% in anaesthetics and 100% in general surgery. So really, what I would say to you is, even if you don't do interview training, make sure you prepare. Make sure you put the same amount of time that you would put into an exam, and also understand that this is something that you can certainly become very good at, even if it's something that at the moment you blank out and are extremely worried about. Does anyone have any questions that they want me to touch on or try and answer? No? Great. The only other thing that I would say is if your interview involves a situational judgment test, make sure you do a practice one, at least one, on the internet. The ICU was giving last year was 2020 was a trial year of having this as part of the process, and this is also another skill that you need to practice. That's all from me. If no one has any questions, thank you.
I just wanted to ask, I'm an intern at the moment and going to be applying for hopefully a crit care HMO job. Any tips about interviews or practice for that, given it comes up very quickly and we're still adjusting to internship?
Yeah, right. So I think always whatever job at that level is making sure you've read the position description really well, looking at the key selection criteria and thinking about how you can meet that criteria. Everyone is so busy, not leaving it to the last minute, writing out your answers, preparing them, and not using other answers that you're seeing on the internet, but thinking about when have I demonstrated the ability to work under pressure, or when have I done that? And it may have been in your rotation in ICU, or it may have been when you were dealing with on a particularly difficult weekend when you guys had a skeleton staff but you were slammed with patients, and that's a brilliant example of working under pressure. So that would be my tip.
Great, thank you so much, Claire.
No problem.
Yeah, I would highly encourage everyone to keep her in mind once again and scan the QR code to have a bit more read. There's a lot of information on the website about what to expect in your interviews and what Claire Berry Consulting can help you with. Thank you so much, Claire. Now I'd like to introduce our speaker for the night, Dr. Ravini, who's an ICU trainee currently at Monash Health. I've had the pleasure of her being my ED registrar when I was a third year in Bendigo. And she actually got me very sort of passionate about crit care. I remember coming in the evenings and late night to get some more experience in ED, and she would get me very much involved, and she's very passionate about teaching. I'll leave you, Ravini, to introduce yourself and the rest of it. Thank you so much. Just to flag, we're going to be doing Q&A on Slido, which is posted in the chat. Here you can just post any questions you have, as well as upvote the questions you would like answered, and then we'll just take it from there. Thank you.
Okay, hi guys. I assume you can all see the screen and hear me. Now, if you can give me a thumbs up if you can. Yeah, that sounds good. Great. So I am new to Monash, the Monash network, and I worked in Bendigo for 5 years, as Nam said. So my background is a little bit convoluted and probably not the most straightforward way to medicine. I was an engineer in a past life. I did aerospace, finished it, then worked for a couple of years in this aerospace industry and decided it wasn't for me, and then got into medicine. And I do have a postgraduate secondary certification in clinical ultrasound. I'm very passionate. So if you see me in the ICU, you'll probably see me holding a probe. And I started dual training in emergency medicine and intensive care. So I've been a registrar for about four years. Yep. And I started in emergency. It used to be my passion. I gave it up last year. So I'm now currently only intensive care, and I'm happy to talk to you about that decision-making process. Certainly critical care, I wish there was just a college of critical care because I love all three. And I've certainly worked in all three as a registrar. So definitely, I wish I could work in all three. So I guess I'm here to talk to you about why would you do intensive care and why I chose intensive care. And just to give you an overview of what happens in intensive care, because some of you guys may not have had a rotation in intensive care or have been into a unit before, tried to put in some very sexy photos of what intensivists do. Don't know if you can tell it's a bit transparent. Top left is a ECMO machine. Top right is my passion, which is a bit of retrieval, jump off helicopters. I actually got to be in one. I'll tell you the story if anyone wants to know at the end of the presentation. And the second one's a ventilator, and that's an Lvad, or left ventricular assist device, which is used in heart failure. And certainly you see that a lot in intensive care at the Alfred, where a lot of the heart transplants happen. So it's a very sexy world if you're considering intensive care, but I feel like I'm probably talking to a lot of the converted, so as to say. So in terms of applying, I think unfortunately they've just made the application process just a once a year thing now. Used to be twice a year. And they have these eligibility criteria that you have to go through. And if you qualify for all of them, I think you are eligible. But I think now you have to supply a CV and they grade it. I'm not sure if that's actually used as part of your, part of how to get in, but you also now have to sit a situational judgment test. So definitely take Claire up on her offer and do the SJT online. I was one of the lucky ones, didn't have to do any of that. Two of the intensivists were happy with me to sign me up, so I was quite lucky. Now, in terms of training, I think it ends up being about 4 to 5 year training program. You have to do a foundation training for about 6 months. Without doing that, you can't actually sign up to the college. And core training, or core ICU training, is 24 months. So you only have to do 2 years of ICU. It's not quite enough, so a lot of us end up doing a lot more than that. And further training, you have to do clinical anesthesia for a year, clinical medicine for a year. So this is general medicine or long-term medicine. And then you get to do an elective, for example, retrieval medicine. And as part of these rotations, you do have to have some rural exposure and some pediatric exposure. Now, having trained in the country for a fair bit of my training, well, most of my training, I can highly recommend that, just because you get a lot of hands-on experience. So if anyone wants to ask me about that later, I'd happily talk your ear off. So I think one of the questions that I was asked was, well, what does a registrar do? I mean, we know what an intern does, right? They go around, they write notes, they order bloods, they order x-rays, and essentially keep the teams from not falling apart. Without an intern, the hospital will fall apart, I can tell you that. And in intensive care, the residents actually perform the function of an intern, or they essentially hold the unit together. They order all the bloods, all the x-rays, the everything, and they essentially make sure the detail is in there. A registrar depends your seniority. So if you're a senior registrar, you might be, leading the ward round and making most of the decisions of the patients in the unit. Or if you're a junior registrar, maybe you're doing all the procedures. You might make some decisions. Depends where you are. As a junior registrar in the country, I didn't have a choice. I made all the decisions. I ran the ED overnight. So you end up learning how to justify your decisions and make safe decisions. And this is something you do learn on the job. And it continues on as you become more and more senior. You do also, as an intensive care registrar, attend MET calls, so medical emergency team calls, and code blues. So I think in Victoria, in all the hospitals, you are the team leader for a code blue. So what I mean by that is that a code blue can be an airway emergency or a cardiac arrest, and you're responsible for coordinating the arrest. I'm not sure how many of you have been to an arrest. They're very chaotic, especially in the wards. There's a cast of thousands, no one knows what to do, and there's a crash cut somewhere, someone's trying to do CPR, maybe the airway is secured. So you really need a team leader to essentially go from doctor's ABCD, do the ALS algorithm, make sure everything's rolling while you figure out why this person arrested. Or medical emergency calls, they're quite important. It's one of the ways that patients end up in ICU. The other way is emergency. So this is a system that was set up recently, like fairly recently. I think it was only like 30 years old, where it's a way of recognizing deteriorating patients. So all the OBS we do, they're there for a reason. Any derangement in OBS would suggest that they are deteriorating. And I'm sure you've heard this 1,000 times, that the most sensitive sign is a high respiratory rate. So we often get, MET calls for that, and we always worry. But you guys as interns and residents are essentially the afferent arm. You guys raise the alarm, and intensive care registrar and a medical registrar would come and essentially try to figure out what's going on, and do they need to come to ICU, or do they need a higher level of monitoring? That's essentially what an ICU reg does. They either do inside the unit and do lots of ward rounds and make sure that patients inside are okay, or they go out to the wards and make sure the rest of the hospital is okay. So there's two different aspects of the job. And then you might wonder, well, who needs intensive care? It's not really, sometimes it's very clear, if you're arrested, you need to get to intensive care, you need support of all sorts. But sometimes it's not so clear. And that's where some of the conflicts will come up. And I'm sure you can come up with lots of interview scenarios if you work as a resident in intensive care where this will happen. So essentially, anyone who needs organ support will end up in intensive care. So that can be brain, that can be heart, that can be lung, that can be kidneys. You can say liver, or any sort of transplant as well. So it depends on the levels of intensive care. So Monash is the tertiary intensive care unit. So we do cardiothoracics and neurosurgical, plus sepsis and everything else. In terms of how people get there, as I said, MET calls where they deteriorate and you identify an organ that needs supporting. So for example, low blood pressure, they need support with their vasculature and their heart, for example. Or low urine output, maybe they're anuric and their kidneys aren't working and they need to come to ICU for support for their kidneys. Or they're low GCS and they're losing their airway, so they need airway management and they can't stay in the ward because we need to breathe for them. So it's especially helpful, especially if you're in ED, for example, and an ED registrar, to refer to intensive care. It's really helpful to think about it as, well, which organ do I need support for, and what am I referring them to ICU for? Just a tip if you're heading down the ED pathway. So I thought I'll talk a little bit about what you might see in intensive care, because some of you may not have made it into the unit. We're all about monitoring. You'll see that there's huge monitors at every bed. There's a nurse by the bedside, it's 24/7. So it's 1-to-1 nursing mostly if they're an intensive care patient, or 1-to-2 nursing if it's a HDU or high dependency unit patient. So I wish you guys were in front of me because I would ask you what this is, but it's a SATS probe. Obviously, oxygenation is really important for us. This is one way of measuring it. And you'll notice that intensive care is all about measurement. Some things don't matter, some things do, but we measure everything. And does anyone want to have a guess at what this is? It's kind of easy. You don't want to jump out? No?
It's an art line with the transducer.
Fantastic, Andrew. Yes. So while you're there, why might we use an arterial line and not just a blood pressure cuff?
It allows you to get a more accurate reading, especially in like hypotension.
Yep. So definitely it's more accurate, and also it gives you a beat to beat blood pressure. As you might know, in the wards, you know, the blood pressure cuff takes about 2 minutes to really give you a blood pressure. That's not fast enough for intensive care. So this is one of the first lines that we will insert, and this is probably one of the first lines that you will get to do as a resident if you come to intensive care. But just a bit of warning, it is one of the hardest lines to do. I still fail many ART lines despite doing them for 5 years. But it is one of the most important parts of monitoring in intensive care. So then you think about all the access we need. So we can't just have a, you know, peripheral cannula. We need all sorts of lines. So you need central venous lines, or CVCs as we call them. We might use them for, you know, support of the blood pressure. So you can use vasopressors, or we might need them to give, you know, 50% dextrose, or we might need it to give inotropes. Or you might end up with a PICC line if we're thinking long-term antibiotics, for example, for our endocarditis patients, for example. And you might end up with a VASCath. Who knows what a VASCath is? Jump in, anybody. There's no wrong answers. Okay, a VASCath is a very large line used to pull blood and push blood in to dialyze it, essentially. So it's if we don't have a fistula or anything like that and the kidneys are failing, we would typically insert a VASCath. And it's much bigger than a central line. And we can talk about that later if people are interested. So you'll see a lot of these. This is the second sort of line that we would normally put in because most people would need some support cardiovascularly. Who knows what this is? It looks like a Dalek, if anyone knows what that is. Anybody? I'm sure you've seen this around if you... So this is essentially
hemodialysis unit.
Yeah. So it's so it is our version of a hemodialysis machine. So the only difference is a hemodialysis you can do in 4 hours. You can pull blood really quickly and then, you know, push it through a filter and give it back to the patient in 4 hours. You can do the whole blood volume. Whereas if we do that to our critically ill patients, they're going to get even worse just because they can't support that amount of blood going out of the body. So this is a slower version. It's renal replacement therapy is what we call it, but essentially it's dialysis. So looks like a Dalek, works very slowly, and this is essentially kidney support. Now, everybody should know this, you know, COVID times, what's this?
It's a ventilator?
Yes, it's a ventilator. Essentially, it pushes air in, so positive pressure ventilation. It just pushes air in and let the patient breathe out. There's several ways of doing that. So you have, you know, pressure control ventilation or volume control ventilation. The only difference is that in pressure control, you control how much pressure you're giving the patient, and volume control, you control how much volume you're giving the patient. And you observe the other parameter. So in pressure control, you observe the volume. In volume control, you observe the pressure. We can talk about that as well, because that all sounds very fancy and too much, but essentially it's a machine with if you think about it, a piston that pushes air in and let the patient breathe out. Not very fancy at all. Lastly, but not least, you guys might not know what this is, but it's the latest and sexiest toy of intensive care. Who wants to have a guess at what this is?
ECMO?
Yes. Yeah, it's an ECMO machine. Extracurricular membrane oxygenation. So I just want to point out, I got really excited when I first got to see this in person. If you look at this line, it's like velvety, you know, maroon. And that's actually blood that's pulled from the patient, which is deoxygenated. And if you look at this one or them together, look how bright that is. That's oxygenated blood. Like that's physiology in action in front of your face. And that like happens in real life and is the best thing you could ever see. I'll tell you about that story maybe after we finish. I'll just finish with what you do in an ICU ward round. Now, I'm sure if you guys are interns or residents, you've done many ward rounds. You've done general, Gen Med, Gen Surg. ICU ward rounds are long, very, very long. If you don't like ward rounds, do not do ICU, because majority of your job is essentially rounding. You do a forever round on your shifts. What you do essentially is look through all of their organ systems, make sure we've covered everything. You have to think about, well, have we got the diagnosis right? For example, it's not clear sometimes why people are in shock. So there could be distributive shock, it could be cardiogenic shock. In terms of distributive, is it anaphylaxis or is it sepsis? Do we need to cover with antibiotics? Things like that, where if you made a diagnosis, have we got the right diagnosis? Which teams do we need? Do I need a general surgeon to take the gallbladder out to control the sepsis? Or do I need a cardiothoracic surgeon because they've got obstructive shock from pericardial tamponade? And do I need to open the chest? So you figure out what's going on disease-wise, and then you do some housekeeping. So I'm sure you've heard of fast hugs, or fast hugs in bed, as per Chris Nixon. Essentially, that all stands for things we need to do to keep people at homeostasis, essentially. So, F is for feeding, A is for analgesia, S is for sedation, T is for thromboprophylaxis, so on and so forth. We essentially go through all of that, make sure, they're fed, they're covered for their DVT prophylaxis. Are we making sure that we talk to the family? Are they aware what's going on? Do we need a family meeting? Do we need to talk to any other teams? Have we got the sedation right? Like, are they too sedated? Is their glucose okay? Do we have all the numbers and the right, like the electrolytes? Do we have all the right numbers? So, is the K 4.0, MAG 1.0? Essentially, we just make sure that the body is at homeostasis during the ward round. So each patient would take about half an hour, and in a pod you might have 10 to 12 patients, so you can tell it goes on for a while. But it doesn't stop after a ward round like you might in Gen Med. You just keep going around and around and around, because it is intensive care after all, and you should be, there at the bedside of most patients all the time. But it is what I found the most rewarding, because often you will get to talk to someone's family at their worst day or their worst week. Their loved one may have had a cardiac arrest and they're not waking up, and they're looking to you for answers. They're looking to you for support. They're looking to you for humanity. So I find intensive care gives me the right balance of science, technology, medicine, and humanity. It lets me talk to people and, be empathetic towards their suffering and be a crutch when I can. So that's why I am doing intensive care. I might stop it there and open the floor up for any questions you might have. Hopefully that was a zoom around in ICU.
Amazing, thanks, Ravini. I'll just share the screen of questions that we have coming up, and then we can just go through them. Is that shared? No.
No.
Let me try to figure it out. Is that sharing? No. I'm stuck.
Oh, I have a question on the chat.
Okay.
This is a direct message to me. So, have you ever met colleagues doing ICU who do jobs in resource-limited settings? How do they fare in those settings, given that ICU docs work in tertiary hospitals? I was interested in ICU, but want to work for Doctors Without Borders. So that was Wai Chung. I hope I'm saying your name right. Okay. I will answer those questions. Wow, that's Interesting. So I don't personally know anyone who works for Doctors Without Borders, but I am also interested in Doctors Without Borders, and I just saw an advertisement for intensivist working to work for Doctors Without Borders. So definitely, I think that's a thing. It didn't used to be, because I think the anaesthetists used to manage the intensive care units, but I think it's increasingly becoming a niche area. Certainly, it's a challenging field because if you think about it, in the field, you don't have power. That's one thing that would restrict an intensive care unit being in the field, because for everything we do, we need electricity, batteries, power of some sort. So if you're in a war zone, if you can't guarantee continuous power, your ventilator needs to be able to, ventilate someone, or need to have a manual ventilator where you ask someone to just keep pumping. But I think it's a thing. Unfortunately, I don't know anyone, so I can't put you in touch. But just look out for, any ads and stuff. But usually it's for fellows of, intensive care medicine. So there might be a fair while to go yet, but hopefully by the time we're all qualified, it's an established field. Peter Chen says ECMO. I'm not sure. Oh, that's an answer. Okay, sure. Okay, I will look at these questions. So why did you leave emergency medicine for only intensive care? Really good question. I pondered on this for a good year and a half, maybe 2 years, and I still wonder some days. So I'll tell you why I loved emergency medicine. So emergency medicine is somewhere you get a patient undifferentiated. You got 4 hours to figure out what's wrong with them or what you need to support and stabilize. Like, it's a quick think on your feet, get a diagnosis of some sort. That wasn't what worried me. I love that aspect of intensive care, emergency medicine. I love that aspect. There's trauma, there's sepsis, there's, all sorts of things that come through the door. What I found really difficult was the uncertainty of the people you sent home. So a lot of the time, a chest pain, you do serial troponins, you say, sure, like your history and exam and investigations don't sound like you're having an acute event, but you need to get this and this and this test. So you're safe to go home, but you don't have any guarantee that they are not about to have a STEMI. They might have a STEMI in 2 hours, 6 hours, 8 hours. Or you might not know what they have. For example, abdo pain. You've done every investigation under the sun you can safely and cost effectively, but you don't know what's wrong with them. You can say that maybe they're not imminently dying, but they could die within the next couple of days. So that kind of thinking was really got to me. I think I worked through it in the end, but I didn't find emergency medicine that satisfying because of that's one of the reasons, and also the 4-hour rule. I really hated the fact that I was put under pressure to get someone out the door in 4 hours, whereas in intensive care, I get to do something similar to emergency medicine, but I have all the time in the world. So that's why I left emergency medicine for intensive care. Hope that's a good enough answer. How significant is research when it comes to getting onto ICU? So it hasn't been, but I hear there's a section on the CV for research that they're scoring now. So I think it doesn't hurt to have 1 or 2 publications, but certainly they don't look at it as a way to employ people or getting onto the program. So I wouldn't worry too much. Try and get something published so that you don't leave that section blank. Like I only have 1 publication. I'm just getting onto my second. So it's really not that big of a deal. It might be in the future. So if you're an intern and you're looking at getting into ICU, say 2 to 3 years down the track, I would start working on at least a couple of publications. So any tips about getting on the critical care HMO role, and would that help to get onto the program? So I hear, this is all hearsay because I've only been here for 3 months at Monash, that the critical care, I think the senior SRMO role is essential to getting onto, say, anesthetics. But I think it also helps to get onto intensive care. I certainly have some residents that you can see how interested they are and how good they are. And certainly, like, I wouldn't hesitate to recommend them to the consultants, because we work a lot with the residents as registrars. So certainly just getting a rotation would help. So getting onto the critical care HMO role would be really helpful, I would say, for any sort of critical care position. Are most people in ICU dual trainees? And if so, are they mostly ED-ICU, or ICU anesthetics, or ICU physician? Good question. So there are two schools of consultants at the moment. So there's the older consultants who are mostly dual trained. So they're dual trained in ICU anesthetics or ICU physicians. When you say dual training, it's a little bit of an honorary ICU training thing, because there used to be physicians or anesthetists that would run the ICU. So they were offered, I think, honorary fellowships in CICM when the college was established. So you can tell there's a cohort of consultants that are dual trained, and then there's the newer consultants who are just trained in like FKICM, just ICU. The only thing I would say is it's really hard to maintain like dual training, like even as a registrar, let alone a consultant. The reason being, so if you ever want to practice evidence-based medicine, it's really hard to maintain like an awareness or knowledge about the evidence that's out there. For both specialties, because the focus is different, right? So for anesthetics, it's all about analgesia, anesthesia. How well would you, how quickly can you give the anesthetic well? Like water anesthetic would be, valuable for neurosurgery. So it's a very different focus. Or emergency. Well, what's the quickest way of diagnosing chest pain? Or what's the safest way to send someone home with chest pain, for example, the ED, like Ottawa ankle rules, for example. So they're more about decision trees and decision making or diagnoses in ED, whereas ICU is mostly about, well, what for example, vitamin C in COVID. So it's just a different focus. So for you to keep up with all of that knowledge is really, really hard. And I think you end up feeling like you're not good at either one. So while you can dual train for a bit, I think I would recommend you pick one if you can. Does being international non-PR that completed medical school internship residency in Australia, including ED-ICU terms, affect employment? Or that's a tough one, because I think that's more to do with the hospital than the unit itself. I think certainly if you can get a job with the unit, it shouldn't matter, because I think you can sort the rest of it out. But I must say, I don't know that. That's a HR thing. So you might want to email people and culture at Monash. Sorry about that. So next question is, I know the registers do 50% nights. Does that continue as a consultant, or do you just become on call? Good question. Depends on the unit. So Bendigo is a very small unit. So I was the only reg on call or on overnight, which meant, like, for example, my colleagues might be their first year of being a registrar. They don't know how to do lines. They can't tube. So the consultant essentially comes in a lot at night. But in a tertiary centre, they're essentially just on call. So if someone deteriorates, they get a phone call. Otherwise, we maintain the unit overnight. But depends on the unit. So it is a hard slog. So heard from a consultant that ICU can make you very jaded. Lots of politics and lots of debts. How has your ICU experience been so far? I love this question. So I'm very philosophical, or I like to philosophize, if that's a word. So being jaded is up to you. I think there's certainly factors that would make you burn out, can make you very, very jaded. I've tried not to become jaded. I think just because, like, I do things outside of work. It's not, my job is not my life. I bushwalk, I rock climb, I cycle, I certainly go out with my friends, and my job is just a job at the end of the day. That keeps me grounded. So when it comes to the politics and the deaths, I can certainly manage it a lot better that way, or at least I think so. The politics will always be there in any job. It's not just ICU. If you're in ED, everybody hates you. That's what it felt like. In anesthetics, it was just like nobody wants to accept your patient that came to have surgery. So it just feels like, because it's such siloed medicine, it feels like you're the only one fighting for your patient. So it's easy to kind of get caught up in that, but you can certainly sit back and look at a different perspective, and not become jaded about it, or recognize when you are becoming jaded and do something about it. Certainly I've experienced the politics, you say medically accepting someone and then there are no beds, and you can get into this fight of, well, what do you do? Or the surgeons want to order a CT and we don't, but you end up kind of coming to a compromise. So it's like any relationship, I would say. So I think it's just about how you approach life and your job. I don't know if that answers your question. Hopefully it does. Okay, any online resources or books you would recommend for ICU? So O's Intensive Care Manual. It's basically the Bible. Apart from that, all of the primary ICU textbooks, I guess, which you will pick up, just because to understand how the monitoring works, how to understand the physiology and the pharmacology, like, for example, Cameron Power, Principles of Physiology for the Anesthetist, that's a really good book. I have it in front of me just because I've been studying. Or Peck and Hill, which is the pharmacology book. You can read around it, so you don't necessarily have to buy books, but O's Intensive Care Manual would give you just an overview of like ICU therapies. So next question I think is, if you're interested in pediatrics, would you do ICU, then choose pediatrics as a fellow, or do you do pediatrics and then an ICU fellowship? So how ICU or PICU training works is that you get into the College of Intensive Care, then you to take the pediatric training pathway. I think there is a way to do pediatrics and then sign up to ICU, but I think now you can just do PICU. I'm an adult intensive care trainee, so I'll do like 6 months of PICU, but they will do mostly PICU and then do like 6 months of adult. So essentially you sign up to the college, you sit the primary, and then you choose essentially all the pediatric ICU training time. So I hope that answers that question. Oh, there's 6 thumbs up for this one. Are there any courses or skills that are valued for ICU applications? Are you basic? And how? Yeah. So I would recommend some of the courses. So basic will give you an understanding of all the monitoring and the ventilation basics, how the ventilator works and what modes are there and what does that actually mean, how do outlines work, a little bit of that. Certainly to become a registrar, you do need basic. It just really helps. I would definitely do an ALS course. It helps to do, if you're an internal resident, you could just do ALS 1, which is I think 1 day and only like $200 or something. But certainly if you're trying to get onto a ICU program, I would do Advanced Life Support 2, which is a 2-day course. It's really, really good. You get an understanding of how to manage a code. Even if you already know, just kind of gives you a format and framework to approach that. Other courses, I mean, it depends. They're not that important. So basic and ALS are the ones that I would really recommend. Certainly there are others. You can just do them as a registrar. They're so expensive. Just wait till you're paid reg wages. What's the difference between a ventilator and Cpap? Good question. So if you're actually talking about the machine, a ventilator can also do Cpap. So Cpap is continuous positive airway pressure, right? So it's essentially a machine blowing air at a certain pressure all the time. It doesn't change. As opposed to BiPAP, which is a bi-level positive airway pressure, which gives you, as the patient takes the breath in, it gives you more pressure. And then as the patient takes the breath out, it kind of drops back down to a baseline level. So they're the two modes in non-invasive ventilation. Whereas a ventilator or mechanical ventilation is essentially a tube in and you connect it and you just have a different mode. So it's just a manufacturer thing. You can certainly ventilate someone in the Cpap mode, but they're doing a lot of work through that tube. So they're inhaling by themselves, the machine doesn't help them take a breath in, and then they're pushing out against pressure. So if you wanted to really see what their respiratory function was like and how strong they were in terms of their breathing, you could certainly just put into a Cpap machine while they have the tube in. And certainly you can see how they do. But that's the difference, if that makes sense to you. Whoever asked that, I don't know, can they speak up? Nam, does that make sense to you?
Yeah, kind of. So you're saying that a ventilator, though, you can put it in Cpap mode, but it has other functions,
Yes.
essentially, and you can take over full control of the patient's lungs.
Absolutely. Yeah. So I guess to think about it is there are mandatory modes where you can essentially you breathe for them. So you push in every breath. So mandatory modes are what we talked about earlier with the pressure control, the volume control, all of that. And when you're talking about Cpap, continuous positive pressure, you're essentially talking about a spontaneous mode or when the patient's breathing spontaneously and you're taking away a bit of support and you're only just kind of helping them out a little bit, if that makes sense.
Yeah, that makes sense.
Yeah. Can you tell us about your retrieval work? I certainly haven't done retrieval rotation, but I got to be in a helicopter. So it was, I'll tell you the story because I love telling it. I just wish you guys were here because I could show you a photo. So it was my 3 months into my first ED Reg job. So I was a first year registrar. I was very green. Loved the ultrasound. So this lady came in with shortness of breath and I was all like, okay, let's do the chest x-ray. And while the chest x-ray, you know, they were being called to it, I just put a cardiac probe on their chest and found out that she had a massive pericardial effusion. The heart wasn't struggling at the time, but it was too big. And in Bendigo, we don't have cardiothoracic. So we called the cardiologist and they said, no, not even touching that. They need to go out of Bendigo. So we called Adult Retrieval Victoria, or ARV as we call them. ARV is run by mainly paramedics. And the flight paramedic that day said, not willing to put a needle in their heart if they arrest, because that's the treatment. If they arrest, you have to drain the pericardial effusion. My boss was quite comfortable that this lady wasn't acutely going into cardiogenic shock. So he just said, well, I can't go, so why don't you go? Because they asked for a doctor escort. So first year registrar, PGY3, I said, sure, and had a central line kit just in case they're arrested. And ended up getting on a helicopter from Bendigo to the Alfred, just a 35-minute, really sweaty, really uncomfortable trip, and delivered them to the Alfred ED. That was like my first exposure to retrieval. And I plan on doing a retrieval rotation now, hopefully with live flight in the future, maybe next year or the year after. So ask me in a couple of years and I'll tell you more.
I was wondering, as an ICU registrar, or even like later on, do you get opportunities to do a lot of retrieval work? Or is that ED?
No, it depends who you work for. So retrieval mainly depends on, so like ARV, or like you can have a side job as an ARV physician, or like life flight. I certainly know certain, like there's lots of intensivists, emergency physicians and anaesthetists, all three critical care physician jobs. They can go and do retrieval as a separate job. So it's not restricted to emergency medicine, certainly not. So you can easily go and work for the companies that do retrieval or the hospitals, yeah. So what are the major differences between rural and metro practice in ICU? Oh, interesting question. I love talking about this. So rural hospitals, essentially the difference is that we don't have cardiothoracics or neurosurgery. We have most other specialties, or some may end up with just, general medicine, general surgery. So essentially you end up treating a lot of trauma or a lot of sepsis and pneumonias and things like that. So you still do exactly the same thing. So like you can support their kidneys with filtration, you can still ventilate them. But as a registrar, essentially you're the only one. They don't have enough money to say have a transport reg and an outreach reg. And, in Monash ICU, for example, is very well staffed. We have an outreach registrar, we have a senior registrar and 2 junior registrars at night, for example. In Bendigo, I was the only one. So I did code blues, met calls, and run the ward all on my own with a resident helping me out. So in terms of the actual practicality, you are in the deep end in the rural ICUs. Metro, you're a lot more supported. But in terms of what you see, it'll be a lot of sepsis and a lot of trauma in the country ICUs, whereas you get the full experience in the city. So you certainly need to do both, so you understand the difficulties and the differences. But that's basically it. It just depends on what services the hospital offer. So how many years after graduating does it take most people to get into ICU? Good question. It's very variable because it's a specialty that people kind of, I don't know, I've seen like my mentor, Dr. Brandon Murphin, I think did full ED fellowship, worked in it for 10 years, then got into intensive care. I certainly got into it about PGY4, some of my friends PGY5, PGY6. Certainly it takes a few years. Like PGY4 is probably the average, just because you kind of need experience as a doctor. You need to recognize when people are sick and when people are not, and learn to trust your gut. You guys would already know which people are sick, but I bet you they probably won't, like you probably don't trust your gut as much. So you kind of learn these patterns, or learn to recognize these patterns, and that takes practice and that takes a few years. So aim for PGY4. That's kind of probably the average at the moment. So as an intern in a big hospital, I always feel so useless at Met calls, code blues. So many people arrive. Patient usually has IV access. Someone is scribing. Any tips? Oh, I love this question. So as an intern, I always felt like my job was to get that IV in, right? Like that's what you could do. I always went for the IV because I know I can do that. But can I tell you, as a registrar, I really love it when you guys are there, because as I turn up, I have no idea about this patient. Like, I don't know what they've had. I don't know what their, quality of life is. I don't know who their, family is. I don't know if they're from home, a nursing home. Is this what they look like when they came in, or is this a difference? Like, had they changed? So you are essentially my eyes and my ears and my essentially all the input. So you are so valuable. I don't want you to feel like you're useless, because without you, literally I scratch my head. And also as a new registrar to Monash, EMR, don't even ask. So like trying to get information is impossible. So you are information for a registrar. So that's the biggest asset at a Met call. So you have a lot to give. Forget the IV. One of us will get it in. Your job is to try and present information in some form, even if it just comes out jumbled, doesn't matter. I just want to know about this patient, because you should know all of your patients on your list. I know sometimes it's hard because you have like 50, but any information is good enough. So that's your job. That's why we need you there. So don't feel like you're useless.
And I have to say, like, just doing surge internship at Monash, my surge reg would obviously never be at one of the Met calls because they'll be scrubbed in. And so I was like the bank of knowledge, and initially I had no clue what was going on, and just start spilling thoughts and investigations and obs, and that was apparently really useful, because they're like, oh, okay, that's what's going on, and that help you navigate the EMR. Oh, guys, this is here, this is here, this is here. Let me open imaging, where you have to put in your username and password again. even something as simple as that. So I never even put up cannulas during like a med call. I was just doing that.
Yeah, absolutely not. Like to be like, okay, no, like what's their potassium? What's their, pH? What was the chest X-ray like? Like just to kind of be like, okay, give me information, because like I can do the thinking, or I can figure out what's going on if you give me information. So like you guys are so helpful to like when you're there. And obviously you act as the interface between the treating registrars, obviously like surgery, they're never there. So you have their number, you can just call and be like, hey, the ICU reg wants to do this. Like, is that okay? Or like, do you want to come down or call the consultant? Or, that really helps. And it's an extra pair of hands. So definitely you're not useless. Oh, next question. I love this one too. How is the work-life balance in ICU? What are your thoughts on the health effects of shift work? Oh, tough one. So work-life balance, you have to try really hard. I was not good at this, and I've only just got the balance this year, I think. So it took me 5 years to work this out. It is really, really hard. Because as an intern and a resident trying to get onto a program, I feel like you kind of have this, or at least I did have this attitude that like you really need to work hard, you need to stay behind, you need to do a research project, you need to do an audit, you can't go home on time because it might look like you're not working hard enough or you're not dedicated. None of that is true. You got to set boundaries at work, and I think we are the generation that will change medicine, hopefully. You got to take care of yourself. You got to eat, you got to sleep, and you got to do something outside of work that gives you pleasure, whether it's playing chess with your elderly neighbor, or whether it's cleaning your house. If that gives you happiness, do that, and make sure you allocate time to do that. I certainly let go of a lot of my hobbies like bushwalking when I was trying to get onto the program, not because that was a requirement. I just had this internal dialogue that said that's what I needed to do, and I got burnt out, and I learned the hard way. So take it from me, try and do something for yourself while you're doing medicine. Medicine will replace you in 2 weeks if you don't turn up to work. So it's just a job, so treat it like that and make sure you take care of yourself. In terms of the health effects of shift work, it sucks. It puts up your cortisol, you always feel exhausted, you're jet lagged half the time. Cognitive function wise, I certainly am not back to normal, at least until 3 days down the track from night shift. But the reason I've accepted it is because I love my job so much. So it's only also for another 4 or 5 years until I become a consultant, and hopefully that means less shift work, but I still love my job so much that I am willing to sacrifice that part of my life. So I think you've got to make a decision. Is that something that you're willing to sacrifice, or is that just a no? Then you've got to choose a different path in life. So do most units do 7 days on, 7 days off? Close. Yeah, they do. It's usually 6 on, 6 off, or 7 on, 7 off. Monash is actually a lovely roster where you do 3 days on, 3 nights on, then you have like 6 to 7 days off, and it repeats. And it kind of changes the pattern a little bit. Sometimes you might do 3 days on and then have 3 days off and 3 nights on. This is to keep the continuity of care, because if you think about it, most patients are really complex. Once you get to know them, you don't really want to have another person come in like the next day. I'm loving the weeks off though, because you can go to Hobart for a couple of days or New Zealand for a couple of days, for example. So there's perks to that. Is there a personality type in critical care? I find it really interesting, but I can get anxious sometimes at met calls and don't feel smart enough. Oh, I wish I could hug you, because this is what I feel all the time. So I get anxious. I really do. I had to, when I first started. Oh, sorry, someone's got feedback. So when I first started, I used to have to do like square breathing. So you take a breath in for 4 seconds, hold it for 4 seconds, and let it go for 4 seconds before I walked into a code blue. So I would try and like walk there and then breathe and then walk in, or practice at home in front of the mirror. Okay, like speaking out loud. I think personality-wise, I think it's an approach. I think you've got to have a growth mindset to survive in critical care, and I also think you need to kind of train yourself to, how would you say it? Keep calm under pressure. And I know that's very stereotypical, but you do need to be able to think while there are lots of like stimulation coming your way. For example, in a code blue, people will be shouting things at you or talking among themselves. You need to be able to take control of that and not be overwhelmed by that. So you might need to work on, for example, I had to work on my self-assuredness or self-esteem to be able to think, yeah, I can take control of this room. But more practice you do, the better you get at it. So don't think it's not for you. Definitely work at it and have that growth mindset that it doesn't come to people naturally. But that's all I can say. And in terms of not feeling smart enough, none of us are smart enough. None of us will ever be. There's so much knowledge. And the ones that think they are smart enough are probably deluded, if I may say so. So if you're feeling like you're not smart enough, that's okay. That's how most of us feel. So keep reading, use it as fuel to read more and get to know things more, and look up how an outline works, look up what nitric oxide does, for example. Use it as fuel rather than a barrier, I would say. Hope that helps. As a PGY2 with an ICU term later this year, is there any curriculum you suggest we have a look at to prepare? Life in the fast lane, obviously good to peruse for a brief overview. Life in the fast lane is great. It's a bit hard because I think you'd learn most of it on the job. Are there any podcasts? So you could certainly, let me just bring up my podcast list. You could certainly look at that. Sorry, didn't expect this question. So in terms of my podcast, Coda Change, that's another quick care podcast that you can listen to. You could listen to MRAP, which is an emergency podcast, or MCRIT, which is a critical care podcast from the US, Mastering Intensive Care. So you can listen to things and like read around it. I wouldn't say there's a particular curriculum I would look at, unless you're sure you'll get onto the program and then you can start to study for the exam. But to be a good resident in intensive care, I think all you need to do is be enthusiastic and curious. That's all. We will teach you the rest. So for ICU hemodialysis, is it slower and continuous? Is there a downside to slower rate, i.e. not controlling the level of metabolized and electrolytes as quickly? Good question. So it is slower and it's continuous. So it's usually, the whole thing runs for 24 to 72 hours. Like a filter lasts about 72 hours. So essentially it's continuously running for 3 days. The downside is that the rate of electrolyte shift is slower, yes, but that is not necessarily a bad thing, because if you think about a critically ill patient, so they're often acidotic. It's one of the reasons we would filter them. So that makes their heart really irritable. They're prone to having, like atrial flutter, atrial fibrillations, or arrhythmias. So you don't necessarily want to have big fluid shifts or big electrolyte shifts, because you want to keep things very slow and controlled. That's a reason it's slow and continuous. We certainly have other machines like SLED, which can do it in 6 hours. It's like a dialysis machine, and we can connect that to the PVACCS themselves and do it in ICU, where we do it quickly. So it's not like we're restricted in what we can do. It's just more, this is what we've determined to be the safest and the nicest for the critical care patients. So there is a downside in that if they're really acidotic, like if you have a pH of 6.8, it'll take like 4 to 6 hours for that pH to come up. So you might have to temporize. For example, we had a patient who had arrested and was on adrenaline, which meant their lactate was going up, because that's one of the side effects of adrenaline, got up to about 14, which meant their pH was 6.8. Now, at a pH of 6.8, that's usually not compatible with life, just because the enzymes stop working, the heart's just throws off funny rhythms. So we have to filter them, and that took about 6 hours. So in the meantime, we were giving them sodium bicarbonate to bring up the pH so that we could temporize until we could filter them. So you can do all sorts of things, but yeah, it is one of the downsides. Last but not least, does ICU have a lot of procedures and are the ward rounds more interesting than gen med ward rounds? Or depends how you look at them in terms of the ward rounds. I find them interesting as a registrar. I think as a resident, I probably didn't, because I did do a resident rotation, just because you're essentially just doing the data work. And if you didn't have a registrar or a consultant that asked you questions or explained things to you, you essentially, it's really easy to blend into the background and not ask questions, just do as you're told. So I think it depends on how much you're engaged in the ward round. So like, you can go off and read the latest, article on cardiogenic shock and start talking to the consultant about, well, why would we do this versus that, for example. You would get so much out of that than if you were to just sit behind and, write down the amount of adrenaline and milrinone they're on, for example. So I'm not saying you always have to do that, but if you're starting to get a bit bored because, things are getting, like you're getting used to things, try and jazz it up. It doesn't have to be boring. So that's my only little, and it is full of procedures. And if you're on with me, you can do all the lines. I've done enough lines for my lifetime, sort of. So yeah, it is full of procedures. It's fun. It really is fun.
Nikki Z's just asked, any advice about case presentation for an ICU ward round? Oh,
Nikki, I'm still learning this myself. They're so complex. I would stick to an ISBA kind of format, because that's the easiest way to present them. Because if the consultant has more questions, they can always ask you. So I would start with, this is so-and-so admitted to ICU with blah, and their past medical history is this, that is relevant. And we've done this, and now we're here. So like that kind of thing, because it has to be succinct enough that, the consultant doesn't get bored, but also convey enough to kind of convey all the information. So stick to ISBA is my only little tip. I hope you know what ISBA is. Please type yes if you do. Nikki, thank you.
Amazing. Thank you so much. There were a lot of questions there. I definitely learned a lot. That was amazing.
I hope everyone did too. And look, I'm really approachable. So if you see me in ICU, just come have a chat. I'm happy to have more of a chat.
Yeah, perfect. Thank you so much, Ravini, for that. Just for everyone else, so this event today is recorded. And if you've missed anything or want to revisit, just sign up on our PVACCS page, and we'll send around the links for the anesthetics one as well as this ICU event. We'll also email through other events, especially when it comes to like education, and as well as a careers night closer to application dates about how to apply and get on the program. Awesome. Well, thank you everyone so much for coming, and just want to say thank you so much, Ravini, once again. Definitely learned a lot.
No worries, anytime. Thanks guys. Good luck with all your applications.